So, Lisa, fantastic talk today. Really, really important and exciting developments in your field. Perhaps we can just reflect on a few of the things that you highlighted today, one of which was the concept of tissue-dependent programming of immune populations that remains there, even though cancers become advanced and appear to be driven by oncogenes that you might expect to take precedence over the original host environment. Can you expand a little bit on your thoughts about why that happens?
Well, that's a complex question. Why it happens, I think that the activation of oncogenic pathways is very much analogous to what Dvorak postulated in the early 70s, that tumors are wounds that don't heal. And I see that the activation of the oncogenic programs eliciting uncontrolled cell death or cell proliferation is a wound. And that in order for the tissue to respond, an immune response is all part of that. We see that whereas the tumor cells are clearly evolving, as we saw beautifully before my talk, that the genomics of the tumor cell clearly evolved. We don't see that kind of evolution necessarily in the chronic infiltrates. The kinds of immune cells that we see being recruited in early are very similar to the kinds of immune cells we see coming in late. That said, the transcriptional programs early are different than the transcriptional programs we see in them late. And I think that's more akin to them then being conditioned by the tumor microenvironment. And that conditioning enables more the chronic inflammation that's tumor promoting as opposed to tumor repressing.
One can envisage why tissues that have a exposure to a lot of microbial flora might have very different immune resident populations. But why, for instance, is the breast so different from the prostate and so different from the pancreas in terms of the types of infiltrate you see there?
Great question. Well, certainly for pathogens, bacteria and viruses, all tissues, you would expect that the spectrum of pathogens that a tissue would be exposed to would be different, clearly, based upon location. But damage other than pathogen and bacteria, viruses is also going to be different depending upon the tissue. So for example, if you look in the mammary gland, a branching organ that undergoes developmental changes, activation and resolution of immune programs is all part of the natural biology of the mammary gland. We've seen through several preclinical models where somatic mutations happen in genes that control that branching process. You can acquire tissue changes that are associated with a chronic engagement of an immune response, akin to what we see in these transgenic models of tumor development in the mammary gland. So what I think that biology tells us is that damage is seen by tissues in a tissue-dependent manner, but all tissues have endogenous damage response pathways, and the immune response that we see is associated with that, whether it be pathogen or bacterial or viral.
You're about to kick off some very exciting clinical trials. That's the translation of the work that you've done in interrupting humoral immunity. Tell us a little bit about what you're going to be doing first.
Well, so I have to say that I am perhaps the most excited about those trials. The thought of using rituximab in solid tumors, I think, is remarkably exciting. First of all, it's approved. We know it's safe. So a lot of the hurdles with a new drug other people have already surmounted those hurdles. For pancreas cancer, we see, based upon the preclinical modeling, really a very narrow window of opportunity where we can slow the growth of de novo tumors with anti-CD20 B-cell depleting approaches by themselves, so monotherapy. We're currently doing studies where we're combining the murine version of rituximab with chemotherapy to ask if we can enhance that response. So there might be, if that translates to the clinic, I would anticipate a very short window of progression-free survival, but pancreatic cancers are very aggressive. So I don't think that this will provide long-term durable therapy. What I do think is that this window of opportunity provides us with an additional opportunity to layer in other therapies, such as vaccine-mediated therapeutics that take advantage of that neutralization of the pro-tumoral Th2 response, where we see that there is infiltration then by Th1 phenotyped myeloid cells as well as CD8s. So that would be the perfect window of opportunity for a vaccine, but also for checkpoint inhibitors.
Yes, tell us a little bit about how you see checkpoint antagonists fitting into this jigsaw.
The most exciting thing happening, I think, in cancer right now, cancer therapy, is the appreciation of checkpoint inhibition. We've seen approval in melanoma for the anti-CTLA-4 ipilimumab therapy. Importantly to recognize there, only about 30% of patients respond, which begs the question, what's the difference with the other 70% of patients that don't respond? A lot of data out there to suggest that the difference in the two populations may have to do with immune response, where patients that aren't responding may have a very prominent Th2 immune program that's established, such that when those CD8s come in, they're immediately repressed by a myeloid response, suggesting that if we block that pathway, then checkpoint inhibition will do a much better job.
Right. You also highlighted how blockade of the IL-10 signaling pathway could improve the fitness of cytotoxic T lymphocytes.
Right.
I know this is layering many different approaches on top of itself, but is that how you see the field developing, having multiple inputs?
It is absolutely how I see the field developing. I don't think, well, we know that chemotherapy as standalone therapy provides modest survival advantage, doesn't really cure anyone, nor does it allow cancer to be lived with as a chronic disease. Targeted therapy, I think we'll see very much the same, but I think we'll always see escape from targeted therapy. The genomics dictate that. So combinations of cytotoxic with targeted will provide an added advantage. The beauty of them layering in immune therapy is that immune therapies aren't necessarily going to be based upon the heterogeneity of the tumor cell with all of the mutational spectrum that we're seeing. So pathways that can suppress pro-tumoral immune responses while engaging natural endogenous CD8 T cell responses in combination with targeted therapy, in combination with cytotoxic therapy, I think will get us there, where we see durable progression-free survival that will then enable us to succumb to Alzheimer's or cardiovascular or diabetes or get hit by a bus.
Perish the thought.
Yes.
Now, many people think that converting cancer into a chronic disease and suppressing the problem cells within it requires a chronic intervention. But you showed some striking experiments that transient reprogramming of the local microenvironment could have long-term effects by interrupting the crosstalk between dendritic cells between CD4 cells and macrophages locally.
Correct. Right, so that data is based upon our work in the mammary models, where we see that CD4 T cell depletion or therapeutic neutralization of IL-4 and IL-13 cytokines that are almost exclusively expressed by CD4 T cells provides a platform where the macrophages that are recruited in more of a Th1 state. That, in combination with chemotherapy, which naturally releases antigen, provides for an enhanced dendritic cell response thus an enhanced CD8 T cell response. The approaches that we've taken there are indeed acute in late-stage disease prior to the development of metastasis. And all of those approaches, we see a slower growth to end stage of the primary tumors, but we see remarkable inhibition of metastasis. That's all in neoadjuvant disease. We don't normally treat in the neoadjuvant setting. Surgery is always going to be the best option for a patient to remove a primary tumor. The real question is, will these approaches work with established metastasis? Hard to model, because mice don't like to metastasize, as you know, but also in the murine setting, regulations require that animals be euthanized when primary tumors reach a specific size, negating the ability to develop any of these approaches in the metastatic setting. So the real question is, will they translate? So what we've done to address that is re-engineered our models so that we can remove primary tumors and then let metastases develop. We routinely image the animals and then randomize them and put them onto these studies as they develop de novo metastasis in the absence of a primary tumor, to do proper adjuvant studies. We don't have results yet because it's taken us years to develop these models, but we're hopeful. And I think that really is where we need to focus, and those are the major questions that we need to get at, the difference between neoadjuvant and the adjuvant setting.
Many of the therapeutics that you're developing are antibodies. How do you see those fitting in for metastases in the brain, for instance?
So we're not developing any therapies. We partner with companies that develop drugs. We take advantage of what other people have developed. So clearly, antibody therapy won't work in the brain, obviously for reasons of the antibodies crossing the blood-brain barrier. So for CSF1 receptor, we can deal with that with the selectivity of the small molecule ATP inhibitors that target the receptor tyrosine kinase area of CSF1. There's reason to have cautious optimism for those approaches in the brain based upon a lovely study that Joanna Joyce's lab published a few weeks ago, actually, published in Nature Medicine, where she's demonstrated that CSF1 receptor antagonists do cross the blood-brain barrier and slow the progression of glioma to glioblastoma. Now, if that same biology is maintained with, say, breast cancer metastasis to the brain, and if the brain macrophage is similarly a tumor-promoting cell in brain metastasis, we can hope that we would see the same pathway being antagonized. We don't have mammary models that metastasize to the brain yet to do that validation.
Right at the other end of the progression spectrum, do you see there's a role for immunomodulation as a preventive approach for cancer?
Prevention. Well, clearly the best way to deal with cancer is to not let it happen. We're all in agreement there. Prevention is difficult. Because especially with immune therapies, because you want your immune response to be fit for dealing with everything we come in contact with, without the possibility of developing an autoimmune response because your CD8s are too active. So it's hard to know who to treat, right? The population biology, and based upon tremendous epidemiology, would suggest that therapies targeting the COX-2 pathway lower your relative risk for many types of malignancy. That's prevention, analogous to an apple a day, or an aspirin, an apple. But taking any of the therapies that checkpoint inhibition or what the approaches that we're using into a prevention setting, I think that would be complicated with what then might be the consequence. So, that said, we've gotten very excited about Fanconi anemia patients. So these are patients that suffer somatic mutations, well, heritable mutations, but also somatic mutations in DNA repair pathways. Many of them have enhanced relative risk for certain types of cancers, squamous cancers, breast cancers, pancreas cancers, that arise focally where you can see aberrant proliferation of mutant cells. But in these patients, these early lesions can progress if the patient doesn't succumb. In looking at these tissues, we see an immune response that happens very early as you see the beginnings of proliferation. So we know who has Fanconi anemia. It seems to me that those patients would be poised for prevention of malignancy based upon the hypothesis that the immune infiltrate that forms subjacent to an expanding proliferative lesion could be repressed.
Fantastic.
So you have to know where to prevent.
Yeah.
So another population might be patients that have heritable P53 mutations, folks that have heritable NF mutations, some of these tumor suppressive pathways where there are kindreds. I think suppressing the chronic inflammation that would accompany progression there would be the way to go. But to generically take these approaches into the population at large, I think you risk autoimmune responses that would be just as hard to deal with.
Okay. Just to finish, many of the people who are going to be watching you are young scientists just starting out in their careers. Like you, looking at you as a role model. What's the most important piece of advice you'd give to them, particularly if they're considering a career in cancer immunology?
Be tough.
And with that, thank you very much indeed, Lisa.
Yeah,
A pleasure. Thank you.
Yeah.